So, as I already said, here on the left side, you see an apical 4-jammer view of a fetus with a very dilated left ventricle, poorly contracting. You already also see signs of endocardial fibrinolysis, and this is the classical patient with a critical aortic stenosis sent for intervention. Here in the middle, you see a patient who has a very hypertrophic right ventricle. Ventricle is also small, and this is a patient with pulmonary atresia with intact ventricular septum at risk of growth arrest of the right-sided structures. On the right side, you see a patient with actually a very poor condition, hypoplastic left heart syndrome. You can see that the atrial septum looks quite thick, and you can see also the pulmonary veins down to the pulmonary structures. So this is a patient with an intact atrial septum and signs of a nutmeg lung with a very poor prognosis. So why are we even talking about fetal cardiac interventions? So in 1989, Lindsay Allen from the UK was basically the first person describing the natural history of hypoplastic left heart syndrome, and she was showing that there is the risk of patients with, or fetuses with critical aortic stenosis, that it can happen that this disease evolutes to a hypoplastic left heart syndrome until patients are born. And the same thing is basically true for the patients with pulmonary atresia and intact ventricular septum, also sometimes with critical pulmonary stenosis, that they may become hypoplastic right heart syndrome. And already mentioned the patients with atrial septum intact in the setting of hypoplastic left heart syndrome, the pathologies we see in these patients in the lungs with truly abnormal pulmonary veins, also called then nutmeg lung. So the natural history, I just want to show you some examples. You can see now on the left side a fetus with 25 weeks, same situation, dilated left ventricle, poorly contracting. Just 4 weeks after that time of presentation, the ventricle already looked quite different to the first situation. You see the left ventricle is not apex forming anymore. You can see that the endocardial fibrinolysis is more prominent, and at the time the baby is born, it's clearly a hypoplastic left heart syndrome, so the ventricle is not even close to be apex forming, and this patient underwent univentricular palliation. So that was why Gerald and Wolfgang Arzt started the fetal cardiac intervention program at our institution in Linz in the year 2000 with the very first intervention in a pulmonary atresia intact ventricular septum case. And since then, the program started to evolve more and more. And right now, we are doing about 24 procedures each year, with the majority of patients undergoing fetal aortic valvuloplasty. We already did now 160 fetal aortic valvuloplasties, followed by interventions on the pulmonary valve, and the interventions on the atrial septum in the setting of hypoplastic left heart syndrome are performed much less. So far we did like 10 stents and 4 balloon atrial septostomies. So how are these procedures done? We in our institution use general anesthesia of the mother. We don't use any separate anesthesia of the fetus, and the procedures are done under ultrasound guidance. So we puncture the heart with 17 or 19 gauge needles, depending on the size of the fetus and the size of the respective valves, and also use different balloon catheters. In the setting of aortic ballooning in the fetus, we try to have a balloon to valve ratio of at least 1.2. If we have like the situation also with severe mitral regurgitation, we try not to over dilate these aortic valves too much. And this is just one example of a fetal aortic valvuloplasty. You see here the needle tip just before entering the left ventricle. Sometimes you have resistance because of ribs. Now the obstetrician was able to cross this resistance, and this already with the needle tip inside the left ventricle, just about to go underneath the aortic valve. Here is, at this level you can see the aortic valve. The guide wire already passed the aortic valve, and it's just followed by the balloon catheter. As soon as we see that the balloon catheter here has been seen in the ascending aorta, the needle tip is withdrawn slightly into the cavum of the left ventricle, and then we start with the first ballooning of the aortic valve. Now the balloon is inflated a little bit too distal, and so we pull it more back and do another dilation in a more suitable position. As soon as we are happy with the result, we then deflate the balloon, pull it back into the needle, and then sometimes it's hard to get the balloon back into the needle immediately, and then we withdraw the needle from the left ventricle. And from the technical aspect, then the intervention is finished. So talking about critical aortic stenosis, there are basically two types of patients we are dealing with. The first one I already talked about, with the risk of having a hypoplastic left heart syndrome until the time the baby is born. But there is also the different indication with structures of the left side getting bigger and bigger in the setting of very severe mitral regurgitation. And this is a patient, you can see already the very dilated left ventricle compressing the right ventricle. You see some signs of pericardial effusion, and this is a quite risky situation for the fetus, and maybe this one's not going to survive until term. So when are we talking about evolving hypoplastic left heart syndrome in critical aortic stenosis? So we basically need the aortic valve stenosis as the primary lesion, and then we need the signs of a poorly contracting dilated left ventricle. In the free vessel view, you see that there is flow reversal in the aortic arch, so retrograde flow in the aortic arch. And if you see the mitral valve Doppler here on the left, then you see only very short and monophasic filling of the left ventricle. And the question here is always, is the left ventricle still salvageable? Is the ventricle able to generate enough pressure after intervention? And is there the possibility to have a biventricular circulation after birth? The different situation with mitral regurgitation, you have like dilated left ventricle, but also very dilated left atrium. And if the left-sided structures are just big enough, starting to compress the right structures, you start having congestive heart failure. Here in the middle, you see a classical patient who is just about to deteriorate in the entire cardiac function, a very severe mitral regurgitation, a very dilated left ventricle, also dilated left atrium. And in this setting, you have already up to 100% neonatal and intrauterine mortality. I just want to show you some examples of how much we can do for these patients, especially in the setting with congestive heart failure. You see the baseline echo just before intervention, very dilated left atrium, dilated left ventricle, poor function, and just 4 weeks after successful fetal aortic valvuloplasty, the situation is quite different. You see the left ventricle and left atrium, they look smaller than before intervention. The right ventricle is not compressed anymore. And by the time the baby is born, this was the apical for chamber view with a very quite nice systolic function. And this patient basically didn't need any intervention until the time of 5 years of age. So this is quite a fascinating case, in our opinion, for left ventricular rehabilitation after successful fetal aortic valvuloplasty. But there is also more things going on when it comes to the aortic valves. So this is the situation just 1 day after fetal aortic valvuloplasty in a case with evolving hypoplastic left heart syndrome. You can now see here quite severe aortic valve regurgitation. If you would see this in the postnatal setting, you would probably not be very happy about the interventional result. If we see this in fetal life, we are quite happy because we know that there is aortic valve remodeling during the fetal course. And until the baby is born, you can see that there was a decrease in the degree of aortic valve regurgitation. So the very severe aortic regurgitation decreased to a very mild aortic valve regurgitation. One problem with the patients undergoing fetal aortic valvuloplasty is that not every patient is reacting the same to the successful intervention. So in some patients, we end up with having still quite residual aortic stenosis at the time of birth. Here you can see an epical full chamber view of a patient with quite a hypertrophic left ventricle. This patient underwent the Rosconnor procedure to relieve the left ventricle from this dysplastic aortic valve. In the middle, you see a patient with quite a not completely apex forming left ventricle. There is quite severe endocardial fibroelastosis. You can see the echogenic papillary muscles, and this is basically a patient not suitable for biventricular repair in the beginning. So this patient needed a univentricular palliation. And on the right side, again, a patient with quite a good function, not like completely normal left ventricle, of course, but still this patient didn't need any postnatal therapy until an age of 8 months so far. So what are our results overall so far? So we published this like 2 years ago. So far, it's not possible to have any prospective comparison data between intervention and non-intervention cases. So we went down and compared retrospectively our cohort with the natural history study from Helene Gardiner. And basically, both groups fulfilled the same physiologic criteria. And we saw that our cohort had a quite a higher biventricular circulation outcome compared to the natural history, with 55% compared to 23%. Of course, that's not a correct control group, but still there is at least some difference. But there is now a prospective study going on from the AAPC analyzing the difference between outcomes on a prospective manner. But it's very important not always to think black and white, only biventricular versus univentricular, because there is already some data supporting that if you have a patient undergoing fetal aortic valvuloplasty, that you can give these patients a survival benefit. And the group in Boston showed this, that the percentage of survival at the time of 6 years can increase from 72% to 82%, regardless of if the patient has a biventricular or a univentricular circulation. And we also showed this in our APC study, that there is a survival benefit. So it's quite not only about biventricular circulation or univentricular circulation. And because it's quite different not to think black and white all the time, I just want to show you one example. So this is a neonatal full chamber view of a patient undergoing fetal aortic valvuloplasty, and immediately you would not think that this is quite a suitable patient for biventricular circulation from the beginning, and it was of course not. So the colleagues decided to do staged left ventricular recruitment. So they tried to improve growth of the left ventricle also after birth. And after 6 months after staged left ventricular recruitment, you can see a quite big difference when it comes to the left ventricle. The left ventricle is now apex forming. The function is still quite good. And then the patient was switched from a univentricular circulation to a biventricular circulation. So there is quite a big importance when it comes to postnatal surgical approach also. What about the outcomes when it comes to hydrops cases? So overall in our cohort, we don't have too many hydrops cases, fortunately. So we had 15 cases of hydrops, which included 14 cases having successful treatment. And of the 14 patients, we had 12 being live-born. And overall, from these 12 live-born patients, still 10 received a biventricular management. 7 of those are still biventricular and alive. And if you consider a 100% intrauterine and neonatal mortality, 7 of 14, a 50% mortality with biventricular circulation is quite an achievement also. The problem with fetal cardiac interventions is that these procedures have the possibility to have quite high complications. And we also had difficulties in the beginning with 14% mortality until the end of 2013, but we improved since then, and now the risk of procedure-related mortality decreased to 3.4%. The interesting thing when we analyzed the entire rate of complications was that we didn't see any change when it comes to bradycardia or pericardial effusion which needed to be treated, also when it comes to left ventricular thrombosis. Now, I want to switch to patients with pulmonary atresia with intact ventricular septum. I already showed you this Fotemba view with the hypertrophic and small right ventricle. You can see here, this is the aorta, here's descending aorta, and this is the duct going to the pulmonary artery. You see that there is a reversed flow in the ductus arteriosus. And this here is the Doppler of the tricuspid regurgitation with a quite high pressurized right ventricle of 4.6 meters. And the thing with the fetal pulmonary valvuloplasty is that this procedure is technically more challenging because, first of all, you have a very small ventricle to puncture under ultrasound guidance. And the difference is you also have to perforate the pulmonary valve before you can enter with the guide wire and the balloon catheter. So this is shown here in this picture, the perforation of the pulmonary valve. And as soon as we have done this, we are able to balloon the pulmonary valve. So here the balloon is already in place, and now you can see the dilation in a quite good position. And after the successful ballooning of the pulmonary valve, we do a check with color Doppler just to see if we have any pulmonary valve regurgitation, which is seen here in the red color. If we are able to decompress the right ventricle, we see quite nice changes immediately after the procedure. So before the procedure, you can see you have a very short monophasic filling of the right ventricle, which then changes to a very nice biphasic filling of the right ventricle. And we can effectively decrease the pressure inside the right ventricle, and all of a sudden, all structures are getting bigger. It's not about true growth, of course, immediately 2 days after the procedure. It's just because the ventricle is now feeling better. And we also showed this analyzing that there is a change of outcome in patients with pulmonary atresia intact ventricular septum. So if patients having the risk of a univentricular circulation, we showed that all patients having a successful fetal pulmonary valvuloplasty are now biventricular. And just one of my final slides, I want to show you the last intervention type, which is stenting of the atrial septum in cases with hypoplastic left heart syndrome and intact atrial septum. Here you can see the classical pathologic pulmonary vein Doppler with 2 in through flow, which is quite a bad sign for this patient. And after successful stenting, you can see quite nice left to right shunting across the placed stent. And you immediately see that the pulmonary vein Doppler improves almost to a normal pulmonary vein Doppler. And we don't only use this procedure to prevent the progression of not-MAC lung, we also try to prevent any emergent procedures if we have like a very high restrictive or intact atrial septum with decompressing vein, which works quite nice in our opinion. So fetal interventions, in our opinion, do make a difference. The things we can do for these patients is that we can improve outcomes in fetuses with critical aortic stenosis. In selected patients, we can avoid univentricular palliations in patients with critical aortic stenosis and pulmonary atresia. And in some patients, we can also save those patients from urgent postnatal procedures. And this is now my last slide. If you're interested in fetal cardiovascular medicine, I just want to draw your attention to our upcoming meeting in January 2024. I would like to thank you for your attention. And if you have any questions, just go ahead. Thank you very much.